Coming to the next case, let's see how the child is presenting here. A child aged 5 years was brought with history of delayed eruption of teeth and started walking late around 2 years after birth. Child growth was retarded, malnourished and limbs had poor muscle tone. Legs looked bowed and there was knocking of the knees during walking. Abdomen was protruding. Following other investigations done, and the findings are: serum calcium level 8.5 mg per deciliter, serum phosphate level 2.5 mg per deciliter, serum alkaline phosphatase levels 85 Ka units per deciliter, serum calcitriol 5 nanogram per deciliter. So now looking at the clinical presentation and the lab investigations, you can see that there is delayed walking and growth was retarded, limbs had poor muscle tone and legs were bowed. That is the typical presentation where there is knocking of the knees during walking. And there's decrease in serum calcium level, serum phosphatase level is decreased, alkaline phosphatase levels are increased and serum calcitriol levels are decreased. Looking at all these findings, we can come to a conclusion of a probable diagnosis of rickets in the child. Now, what this rickets is? Rickets is a childhood disease which mostly affects the children between the age of 1 and 3, which is mainly due to the vitamin A deficiency, leading in turn to calcium and the phosphorus deficiency. So now when I say vitamin D deficiency, before that, let's know a little about vitamin D. Now we know that vitamin D is a fat soluble vitamin which is also known as the sunshine vitamin, as body can synthesize vitamin D on exposure to UV rays of sunlight. Now we have the provitamin forms of vitamin D, that is ergosterol, which is vitamin D2, right? So coming to the various functions, what are the biochemical functions? We should understand the biochemical functions to know the clinical presentation of a case of rickets. So before that, what are the dietary sources? Plant sources, not many. It is said that some mushrooms contain vitamin D. When it comes to animal sources, fatty fish like tuna, mackerel, etc., fat liver oil, egg yolk, beef liver are good sources of vitamin D. It is said that sun exposure helps in the synthesis of vitamin D. Hence, exposure to sunlight is a must for us to have adequate amount of vitamin D. Especially, it is said that exposure to sunlight without sunscreen to the face, arms, legs or back before 10 a.m. and after 3 a.m., that is safe sun, twice a week is required for adequate amount of vitamin D synthesis. So coming to the biochemical functions of the vitamin D. So calcium has an important role. It has an effect on intestine, effect on the bone and effect on the kidneys. Vitamin D action on target organs is to maintain the plasma concentration of the calcium levels within the range. As I mentioned, the major sites of action of calcitriol are intestinal villi cells, kidney distal tubular cells and the bone osteoblasts, mainly for the calcium homeostasis. What does it do on intestine? It is mainly to promote absorption of calcium and phosphorus by mucosal cells from brush border cells against a concentration gradient, and is involved in transporting the calcium from the intestine across the epithelial cells into the blood. Now, what is the effect of vitamin D on bone? It plays an important role in the regulation of osteoblast and the osteoclast activities and control of bone matrix proteins. Now, what does it do? It induces the gene expression for the synthesis of osteocalcin, stimulates differentiation of osteoclasts and mineralization of the bones. On stimulation by this calcitriol, the osteoblasts secrete alkaline phosphatase, which increases the local concentration of the phosphorus. The ionic form of the calcium, that is the ionized calcium and the phosphorus, increases, leading to mineralization of the bones. Now, what is the effect of the calcitriol on kidneys? It increases the reabsorption of calcium and phosphorus by renal tubules, thereby reducing the excretion of calcium and the phosphorus. Thus, the role of vitamin D is mainly to maintain the calcium homeostasis and also the phosphorus levels in the body for normal bone mineralization. So now, after looking at these biochemical functions, we can correlate the biochemical basis of the presenting history or the presenting signs of the case. In this particular case, what is presented. So let's see what the biochemical basis is. So vitamin D is required, we know that, for the proper mineralization of the bones. Now, it is due to the impaired mineralization of the new bone matrix due to calcium, phosphorus, or the vitamin D deficiency. What happens over here is bones become soft due to vitamin D deficiency, leading to calcium and phosphorus deficiency, and pliable. Growth is retarded because the bone growth is markedly affected, especially at the epiphysis end of the bone. This is characterized by impeded growth with soft, weak, deformed long bones that bend and bow under their weight as children start to walk, leading to bowing of the legs, hence knocking during walking. The dentition is also delayed, again due to calcium deficiency. The rachitic bone has a different composition from normal bone. In vitamin D deficiency, the calcium phosphate content decreases while the organic matter and water content increases in the bone. Thus, the biochemical basis of the presenting signs and symptoms in the case of rickets, which is mainly due to vitamin D deficiency leading to the calcium and the phosphorus deficiency, hence the presenting features. Now, how does a case of rickets present? That is, what are the clinical features of the case of rickets? Now, clinical features of rickets are mainly the bone deformities, especially the weight-bearing bones are bent due to pliability. Bone malformations also occur due to continuous action of the muscles. Now, what are the clinical manifestations? Mainly the weight-bearing produces deformities such as bow legs and the knock knees. Then, enlarged forehead, which is also called as the hot cross bun appearance of the head. There will be thickening of the skull with bossing of the frontal and the parietal bones due to delayed closure of the fontanelle. In the long bones, laying down of the uncalcified osteoid at the metaphysis leads to spreading of those areas, producing knobby deformity, which is visualized on the radiography as cupping and flaring of the metaphysis. They also present with pigeon chest due to undue prominence of the sternum. Then we have another presentation, that is rickety rosary, that is beaded appearance of the ribs. Another one is a Harrison's groove, also known as the Harrison sulcus. It's nothing but the horizontal groove along the lower border of the thorax corresponding to the costal insertion of the diaphragm. So these are the typical presentation in a case of rickets. We have different types of rickets like nutritional rickets, hypophosphatic rickets, vitamin D resistant rickets, renal rickets, vitamin D dependent rickets, etc. So now coming to the assessment of a case of rickets. So how do you assess for it? Mainly look for the vitamin D levels, which can be reduced in a case of rickets. Serum calcium levels either are normal or slightly decreased. Phosphate levels are decreased. The serum alkaline phosphatase levels are increased as seen in the particular case. Depending on various other causes, we can go for other investigations. Coming to the treatment, correct the calcium and phosphorus deficiency. Then supplement vitamin D 1600 international units given orally per day for 1 month. This can correct before the deformities are developed. So this is about the case of rickets, which is due to vitamin D deficiency seen in children usually aged between 1 to 3.